Okay, let's unpack this. You sent over these fantastic revision notes on deep vein thrombosis in pregnancy. And honestly, that very first line, it kind of lays it out, doesn't it?
Mm-hmm.
Thrombosis and thromboembolism, VTE, are a leading cause of maternal death here in the UK, responsible for a third of maternal deaths related to VTE.
Yeah, that statistic really grabs you. It tells you straight away why this is such a critical topic.
Absolutely. Knowing this stuff well, it can make a real difference. Welcome, everyone, to the deep dive. Today, we're taking those really comprehensive notes you shared and doing, well, exactly that, a deep dive.
Right.
Our mission is basically to go through them, like your own personal revision guide. We want to pull out the most important, the highest yield info you need on DVT in pregnancy.
We'll cover the whole spectrum.
Yeah, everything from, the basics, what is it, why does it happen, then who's most at risk, how pregnancy specifically changes things.
And what it looks like, what else it might be.
Exactly. And crucially, how we test for it, and maybe what tests not to use.
The management, the outlook, potential problems, the full picture.
Think of us as your navigators for this session. We'll guide you through, help connect the dots, and hopefully lock in those key facts for your revision.
Let's get started.
So let's just jump right in, forget sections for a moment. What is deep vein thrombosis in pregnancy, fundamentally?
Okay, so DVT, deep vein thrombosis. In this context, it just means a blood clot forming in one of the body's deep veins. Usually that's in the leg or sometimes the pelvis. And critically, this happens either during pregnancy or in that period right after birth, the puerperium.
Right, okay. And the notes also use that term VTE quite a bit.
Yes, VTE, or venous thromboembolism. That's really the umbrella term. It covers both DVT, where the clot forms and stays in the deep vein.
Day's book.
Yeah, and it also covers pulmonary embolus, or PE. That's when a piece of that clot breaks off, travels through the bloodstream, and lodges in the lungs.
Which is often the more dangerous situation, right?
Definitely. It can be life-threatening. The notes mention the underlying issue involves, well, basically two things. Blood flow slowing down, that's stasis, and changes in the blood itself, how it clots, and how clots break down.
Okay, so DVT is the clot in the leg vein, VTE includes that, and the clot traveling to the lungs, the PE. Makes sense. Which brings us straight to the next big question. Why? Why has this happened? What are the causes, the etiology?
Well, like most things in medicine, it's usually not just one single factor, but the absolute core concept here, the thing you really need to grasp for revision, is Virchow's Triad.
Ah, yes. Virchow's Triad. That's the classic framework, isn't it? The three components.
Exactly. It's fundamental. It breaks down the three main things that make someone more likely to form a clot. Number one, hypercoagulability. Basically, the blood itself is stickier, more prone to clotting.
Okay.
Number two, stasis. This means blood flow is sluggish, it's pooling, not moving efficiently.
Right.
And number three, vascular damage. So some kind of injury or damage to the inner lining of the blood vessel wall.
Hypercoagulability, stasis, vascular damage. Got it.
And the really key insight here, as the notes highlight, is that pregnancy itself directly impacts these factors.
So pregnancy isn't just happening while a clot forms, it's actively pushing things in that direction.
Precisely. It sort of primes the system for clotting, you could say, affects at least two parts of that triad quite significantly.
Which perfectly leads us to who is actually most at risk. The notes give a pretty detailed list.
They do, and this section is incredibly high yield. Knowing these risk factors is absolutely key for identifying patients who need closer attention. The notes group them quite logically. First, you've got the pre-existing factors. Things the woman brings into the pregnancy.
Things she already has.
Exactly. Like having had a VTE before. That's a major one.
Okay.
Or having a known clotting disorder, a thrombophilia. Could be inherited, could be acquired.
Right.
Certain medical conditions, too. Things like cancer, heart failure, autoimmune conditions like lupus SLE, or inflammatory bowel disease, IBD. The list goes on.
What else in that pre-existing group?
Age over 35 is a factor. Obesity specifically, a BMI of 30 or higher. Having had 3 or more previous babies, so parity of 3 or more, smoking is on the list, gross varicose veins, even conditions like paraplegia.
Wow, okay. That's quite a few things you could have beforehand. Then there are risks tied specifically to the pregnancy itself, the obstetric risks.
Right, things that happen during or because of the pregnancy or delivery, like carrying twins or triplets, multiple pregnancy, developing pre-eclampsia, needing a Caesarean section rather than a vaginal delivery, having a very long labor, or needing help with delivery like forceps or vacuum. And sadly, things like stillbirth, preterm birth, or even a major bleed after delivery postpartum hemorrhage, they all increase the risk too.
And there's a third group, new onset or transient factors.
Yes, these are things that might pop up temporarily during the pregnancy or around delivery time. So things like having surgery for something else during pregnancy, breaking a bone, suffering from severe morning sickness, hyperemesis. Also, a complication from fertility treatment called ovarian hyperstimulation syndrome, or OHSS. Being admitted to hospital for any reason, really, or just being immobile for a long time, having a current bad infection, even just long-distance travel, like a flight over 4 hours.
Goodness. When you see them all listed like that, you realize just how many different things can stack up.
Absolutely. And the critical point, especially for revision, is that these risks add up. They're cumulative. The more factors someone has, the higher their overall risk. Maybe a quick check for yourself listening. Could you pause and recall, say, 3 different risk factors from those lists? Pre-existing, obstetric, transient. It's good practice.
Good idea. So you mentioned pregnancy itself contributes directly. Can we dig into that a bit more? The pathophysiology, how pregnancy actually changes things.
Yeah, the notes explain this quite clearly. Basically, 2 main things happen. First, pregnancy makes the blood naturally more coagulable. The balance shifts towards clotting.
Okay, more prone to clotting.
Exactly. And second, as the baby and uterus grow, they physically press down on the large veins in the pelvis, the iliac vein.
Yeah, simple mechanics.
Pretty much. This compression slows down the blood flow returning from the legs.
And how do those two things, the blood clotting more easily and the physical compression, link back to Virchow's triad?
Perfectly. The increased coagulability, that is the hypercoagulability part of the triad.
Got it.
And the compression causing blood flow to slow down from the legs. That is the stasis part of the triad.
Okay. So pregnancy basically delivers a 1-2 punch on Virchow's triad, makes you more susceptible.
That's a great way to put it, a double hit.
Very clear connection. Now let's shift gears slightly. Imagine a patient presents maybe with leg pain, maybe swelling. What else could be going on besides a DVT? That differential diagnosis section is vital, isn't it?
Absolutely crucial. You can't just assume every swollen leg is a clot. The notes list several other possibilities for leg symptoms. Simple musculoskeletal things, a pulled muscle, a strain,
Right.
a skin infection, cellulitis, that can cause redness, swelling, pain.
Right.
Superficial thrombophlebitis, that's a clot in a vein closer to the surface. Less dangerous than a DVT, but can look similar initially. A ruptured Baker cyst, that's a fluid-filled sac behind the knee that can burst. A ruptured plantaris tendon. Or even just simple trauma, a knock or injury they forgot about.
So quite a few mimics for DVT in the leg. The notes also briefly mention differentials if the symptoms are more like chest pain or abdominal pain, thinking PE.
Yeah, briefly. If someone has chest pain, shortness of breath, obviously PE is high on your list, but you'd also think about, say, a simple chest infection. If the main issue is abdominal pain, the notes mention considering an intra-abdominal bleed. Clues there might be specific tenderness, maybe pain felt in the shoulder tip.
Shoulder tip pain.
Yeah. Referred pain can happen with bleeding, irritating the diaphragm. And also a low JVP.
JVP.
Jugular venous pressure. Basically looking at the veins in the neck to estimate fluid status. Low JVP might suggest blood loss. But yeah, for straightforward leg pain and swelling, that first list is your main set of differentials to consider alongside DVT.
Right. Let's talk numbers then. How common is this problem? The epidemiology section gives us the UK context.
Yeah, the stats are important to frame the risk. DVT itself happens in about 1 to 2 pregnancies out of every 1,000. Now, compare that to non-pregnant women of childbearing age where VTE is much rarer, maybe 1 in 100,000.
Yeah.
So pregnancy really does boost the risk, the notes say 4 to 6 times higher.
And that link back to maternal mortality, it comes through strongly here too.
It really does. PEs, remember the clots that travel to the lungs, even though they're only maybe 10–20% of all pregnancy-related VTEs, they account for 1/3 of the maternal deaths from VTE. And overall, thrombosis and thromboembolism remain the leading cause of maternal death in the UK. The data cited from 2017–2019 puts it at about 0.89 deaths per 100,000 maternities.
That's stark. Is there anything specific from the mortality data we should focus on?
Yes, a couple of really striking points in the notes from that 2017–2019 data.
Yeah.
Out of 32 VTE deaths, most 21 happened in the first 6 weeks after birth.
Postpartum period is high risk then.
Very high risk. And look at the characteristics of the women who died. 25% were actually under 25 years old.
Younger women, that's surprising.
It is, and obesity was a massive factor. 63% had a BMI of 40 or more. Overall, 72% were overweight or obese, BMI over 30.
So very significant links to weight and perhaps counterintuitively also affecting younger women in these fatal cases.
Exactly. Really important details from that data.
Okay, so we understand the risks, the numbers. How do we actually spot it? What does DVT or PE look like clinically? The clinical features.
Okay, for DVT, the classic signs are usually in one leg unilateral. You're looking for pain, swelling, maybe the leg feels warm to touch, looks red, erythema. Sometimes you can actually feel a thickened cord-like vein under the skin. The notes mention the left leg is affected a bit more often than the right, probably due to anatomy.
Left leg more common. Okay.
But remember, it might just be tenderness or general puffiness edema. Sometimes, maybe just a slightly raised temperature or white cell count on bloods. And crucially, it can sometimes be asymptomatic, no obvious signs at all.
So you need a high index of suspicion. Can't always wait for textbook signs. What about PE symptoms?
PE often presents more dramatically, usually with breathing problems. Key things are sudden shortness of breath dyspnoea, chest pain, which might be sharp, worse on breathing in.
Pruritic chest pain.
Exactly. Coughing up blood hemoptysis, feeling faint, lightheaded, or even collapsing completely. On examination, you might notice they're breathing fast tachypnoea. Maybe signs of heart strain like a raised JVP. ECG changes can occur. Blood gases might show low oxygen, hypoxemia, and respiratory alkalosis from breathing fast.
And someone with a PE could also have DVT signs in their leg.
Absolutely. They often coexist. Or the DVT was the source.
The notes also quickly mention cerebral venous thrombosis.
Yeah, just briefly. That's a clot in the veins draining the brain. Presents differently, typically severe headache, maybe stroke-like symptoms, usually happens in the postpartum period.
Okay. And the notes bring in practical advice from guidelines like Nissen Archeegir.
Yes, very practical points. They stress getting specialist input early for women with a history of VTE or lots of risk factors, making sure anyone on warfarin is switched to heparin before pregnancy, ideally. Doing that formal VTE risk assessment at the very first booking appointment.
Right at the start.
Yes. And considering preventative heparin LMWH, if a pregnant woman gets admitted to hospital or is immobile for a significant time for any reason. Also using mechanical methods like compression stockings or those inflatable leg cuffs IPC if heparin can't be used for some reason.
So assessment isn't a one-off, it's ongoing, and prevention is built in. Okay, we suspect it based on symptoms and risk factors. How do we actually confirm it? Investigations.
Right. And this section is probably the single most important what not to do point, which the notes really emphasize. For suspected DVT in pregnancy, you avoid D-dimer testing. Full stop.
Okay, why is that? D-dimer is usually helpful for ruling out clots, isn't it?
It is in non-pregnant individuals. But the problem is D-dimer levels naturally rise throughout a normal pregnancy. It's a physiological change. So a positive or high D-dimer is expected in pregnancy and tells you absolutely nothing about whether there's a pathological clot. It just doesn't work to rule out DVT or PE in this context.
That's a critical take-home point. No D-dimer in pregnancy. So what do we do instead?
Imaging is key. For a suspected DVT, the notes say the go-to test is a Doppler ultrasound of the leg veins, also called a compression ultrasound.
Ultrasound of the leg, okay.
A venogram is mentioned as an alternative, but it's much less common now, more invasive. Ultrasound is standard.
And if we suspect a PE,
That usually needs a slightly different approach. You might start with simpler tests, a chest x-ray, an ECG, maybe arterial blood gases. If the patient is very unwell and stable, a portable echocardiogram, an ultrasound of the heart, might be done quickly at the bedside. But the definitive diagnostic tests, according to the notes, are either a CT pulmonary angiogram, a CT-PA scan, or a ventilation perfusion scan, known as a VQ scan.
right, and the notes mention concerns about radiation with those scans, especially for the mother and baby.
Yes, and it's a nuanced discussion. Both involve radiation, but the distribution is different. The CTPA delivers a higher dose of radiation to the mother's breast tissue. This slightly increases her lifetime risk of breast cancer.
Okay.
The VQ scan delivers less radiation to the breast, but a bit more to the mother's lungs and, via the mother's bloodstream, a slightly higher dose to the fetus. This carries a very small theoretical increase in the risk of childhood cancer later on. So the notes suggest that for younger women, especially those with a family history of breast cancer, a VQ scan might be preferred to minimize that breast radiation dose. It's a discussion to have.
Important considerations. What about other blood tests, besides avoiding D-dimer?
Before starting any anticoagulation treatment, you need baseline bloods. That's a full blood count, FBC, a coagulation screen to check clotting function, and kidney and liver function tests, U&Es and LFTs. These are important for drug dosing and safety. The notes also specifically say don't do thrombophilia screening initially when the clot is acute. That testing, if needed, comes much later.
Okay.
And just a small point, if unfractionated heparin is used, less common now, you need to monitor platelet counts regularly, typically between days 4 and 14, because of a rare side effect.
And for antiphospholipid syndrome testing?
That has specific criteria mentioned. It requires positive tests for certain antibodies, lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein I on 2 separate occasions, at least 3 months apart.
Right. So the key message for investigations: image the leg for DVT, image the chest for PE, considering scan type, skip the D-dimer, get baseline bloods first.
Exactly. Know your imaging, no D-dimers out, get the basics before you treat.
Okay, we found it, we have a diagnosis. What do we do about it? Let's get into management.
Right. Management really depends on the severity. Let's start with the standard situation: suspected DVT or suspected PE in a patient who is stable. The notes are clear. The standard initial treatment is low molecular weight heparin, LMWH, given as an injection under the skin.
LMWH, okay. What if it's a massive PE? The patient is collapsed, in shock.
That's a full-blown emergency. The notes say, immediate medical team call, get senior help. They need urgent assessment, potentially an echo or CTPA within the hour. And you need to consider much more aggressive treatment straight away, like thrombolysis clot-busting drugs, or even other advanced therapies. This needs a big multidisciplinary team approach, fast.
Okay, a different level of urgency. For the standard LMWH, is IV heparin ever used?
Yes, the notes mention IV unfractionated heparin might be used initially in massive PE, or if there's a very high risk of bleeding because its effect can be stopped more quickly if needed. And they briefly mention considering newer anticoagulants if someone genuinely can't tolerate heparin, but LMWH is really the cornerstone.
What about managing the DVT in the leg itself? Any other measures besides the heparin?
Simple things help. Elevating the leg when resting. Compression stockings are usually recommended for symptoms. In rare cases, for very large clots high up in the iliac veins near the pelvis, a temporary filter might be placed in the main vein, returning to the heart, the vena cava, to try and catch any clots breaking off. But that's quite specialized.
And this treatment isn't just for a few days, is it? It's long-term during pregnancy.
Absolutely crucial point, yes. The notes state that maintenance treatment with subcutaneous LMWH needs to continue throughout the entire pregnancy. And not just that, but also for at least 6 weeks after the baby is born.
Wow, okay. That's a long commitment.
It is. Women need teaching on how to self-inject and how to dispose of the needles safely. And regular follow-up is vital.
How does this get managed around labor and delivery? It sounds complicated with blood thinners.
It needs careful planning. The team obstetricians, anesthetists, hematologists maybe need a clear plan. The notes suggest options like potentially switching to IV heparin near term, which can be stopped and started more easily. Importantly, LMWH injections usually need to be stopped about 24 hours before a planned induction or C-section.
To reduce bleeding risk.
Exactly. And you have to be really cautious about regional anesthesia, like an epidural or spinal. There needs to be a safe time gap between the last heparin dose and putting the needle in the back.
Right. Safety first. What happens after the baby's born? Postnatal management.
Anticoagulation must continue, as we said, for at least 6 weeks postpartum. The notes say you can either carry on with the therapeutic dose LMWH injections or switch to an oral anticoagulant, most commonly warfarin.
Warfarin postpartum. Is that safe for breastfeeding?
Yes. That's a really reassuring point. The notes make both heparin, LMWH, and warfarin are considered safe to use while breastfeeding.
Good to know.
With warfarin, you just need to be a bit careful initially if the woman has had a complicated delivery with a high risk of bleeding.
Okay. Any mention of preventing long-term leg problems, that post-thrombotic syndrome?
The notes touch on it. They suggest that continuing LMWH for a bit longer, maybe more than 12 weeks in total, might help reduce the risk of developing post-thrombotic syndrome. But they also say the role of wearing compression stockings specifically to prevent the syndrome after the acute DVT. Well, the evidence for that is still a bit uncertain. Stockings are recommended for managing symptoms if it does develop, though.
Interesting distinction. What about follow-up after treatment finishes?
Usually a postnatal review is needed, often in a specialist clinic, obstetric medicine, or hematology. And if thrombophilia testing is indicated looking for those underlying clotting disorders, it should only be done after the anticoagulation has been completely stopped for a while, as the drugs interfere with the test results.
Right, timing matters for those tests.
This section also reinforces prophylaxis, using preventative LMWH doses for women identified as high risk based on that initial assessment we talked about. And it briefly mentions the specific approach for antiphospholipid syndrome, which usually involves both LMWH and low-dose aspirin during pregnancy.
So managing those transitions, starting treatment around delivery, postpartum seems really critical.
Absolutely. Those are the pinch points where things can change, risks shift, and the management plan needs careful adjustment.
Let's zoom out again. What's the overall outlook? Section 10, prognosis.
Well, the good news, according to the notes, is that if it's diagnosed promptly and managed properly, the prognosis for VTE in pregnancy is generally pretty good.
Okay.
Most women make a full recovery without long-term issues.
But if it's missed or severe?
Then yes, that's where the significant complications come in, which leads us neatly into the final section.
Section 11, what can go wrong? Complications.
Well, we started with it, and it's the most serious. Maternal death from PE is the ultimate complication. Thrombosis and thromboembolism remain a major cause, as the epidemiology showed us.
Right. What about the risk of it happening again in a future pregnancy? Recurrence.
The notes state that risk really depends on why the first one happened. Was it provoked by a temporary factor like surgery? Or is there an underlying persistent risk factor, like a known thrombophilia, that makes a big difference to future risk? The notes also just mentioned that thrombophilia itself can be linked to other pregnancy complications beyond just VTE, though they don't go into detail here.
Okay. And that long-term leg issue we touched on, post-thrombotic syndrome.
Yes, that's a really significant chronic complication to be aware of. The notes describe it as chronic venous insufficiency, basically. The veins in the leg don't work properly long-term after someone has had a DVT. It's particularly common after clots in the thigh or pelvis, the proximal veins. It can affect up to half of those patients.
Half? Wow. What are the symptoms?
Ongoing leg discomfort, aching, heaviness, persistent swelling, itching, skin changes like eczema or dermatitis, and sometimes brownish skin discoloration, hyperpigmentation. It can really impact quality of life.
And we mentioned compression stockings for managing those symptoms.
Yes, the notes recommend wearing them for potentially up to 2 years after the DVT to help manage the symptoms of post-thrombotic syndrome, or maybe lessen its severity. But they do reiterate that controversy about whether wearing them routinely after the acute event actually prevents the syndrome from developing in the first place. The evidence there is less clear.
So while PE and death are the most feared acute outcomes, this chronic post-thrombotic syndrome is a really important long-term consequence to keep in mind.
Exactly. It's not just about surviving the initial clot, it's about minimizing the long-term impact too.
This has been incredibly useful going through these notes section by section. We've covered what DVT and VTE in pregnancy actually are.
The why Virchow's Triad, how pregnancy impacts it.
The huge list of risk factors, who's most vulnerable.
What else it could be, the differentials.
Yeah, the UK stats, that crucial mortality data.
How to spot the signs and symptoms.
The investigations, especially remembering not to do the D-dimer.
Definitely. And the whole management pathway, from emergency PE treatment to long-term LMWH and delivery planning.
Plus, the generally good prognosis if caught early, but also those significant complications like PE and post-thrombotic syndrome.
We've really tried to pull out those high-yield points from each part of the notes, link them together logically, hopefully in a way that sticks for revision.
Absolutely. And thinking back to where we started, VTE being a leading cause of maternal death, but also something we can largely prevent and treat effectively, it really leaves you with a key question to mull over, doesn't it? Given that reality, what role do you, the listener, think truly proactive, ongoing risk assessment should play? Right through every stage of pregnancy and postpartum care.
Yeah.
Is that first assessment enough, or do we need to keep reevaluating?
That's a very pertinent question for clinical practice. Definitely something to think about.
Well, we really hope this deep dive into these specific revision notes has been helpful, giving you a solid framework for this important topic. If you found this focused breakdown useful for your studies, remember there are more comprehensive revision materials out there.
Yes. Head over to passthemsra.com. They have comprehensive resources designed specifically to help you master topics just like this one for your exams.
And as a starting point, don't forget freemsSRA.com. Lots of valuable free resources there to kickstart your revision.
Thanks very much for joining us for this deep dive.
Good luck with all your revision.